In our research study, we are examining effort-based reinforcement processing and functional connectivity underlying amotivation in medicated patients with depression and schizophrenia. It is common to see patients with major depressive disorder and schizophrenia display patterns of anhedonia and avolition, or the inability to feel pleasure and the lack of initiative to perform a task respectively. Both anhedonia and avolition contribute to an overall lack of amotivation to complete tasks. In patients with schizophrenia, serotonin dopamine receptor agonists are commonly used to treat amotivation, while with major depressive disorder, a serotonin reuptake inhibition treatment is often used. Although these two treatment options have been suggested to lead to improvement, there is still a lack in understanding how the neural pathways work and a need for a more effective treatment method. To examine the pathophysiological causes of anhedonia and avolition, we will be examining the effort-based decision-making process. This process is used as a cost-benefit analysis system when faced with a decision and takes into account motivation for a specific outcome. Amotivation is viewed as deficits in the decision-making process, causing someone to overestimate the cost for a reward or leading to disengagement in an activity altogether. Many regions of the brain are involved with decision-making and motivation. First, the anterior cingulate cortex is highly involved with decision-making through regulating a cost and benefit analysis system for a specific task. Additionally, the nucleus accumbens functions to facilitate drive and motivation, so one can work towards a specific outcome from an action. The putamen also plays a role in decision-making by calculating how much effort it will cost to achieve a goal. The orbitofrontal cortex will help with decision-making and motivation through encoding the value of different outcomes. In people that suffer from amotivation, there appears to be altered activation in the anterior cingulate cortex. This alteration will then cause an individual to expect an outcome of gain or winning instead of loss. Additionally, there is less activation in both the nucleus accumbens and the caudate nucleus, especially in depressed individuals. This could help to better explain their lack of motivation, since these regions play a large part in drive. Previous research has suggested issues with neural processing in the prefrontal striatal circuitry in amotivated people as well. Taking these brain regions into account, we hypothesize that amotivation in depression and schizophrenia is associated with different patterns of disruption in effort-based reinforcement activity and functional connectivity within the mesonigral striatal orbitofrontal circuit. To test our hypothesis, we looked at 76 individuals, 22 with depression, 23 with schizophrenia, and 31 healthy controls. All participants with a mental illness were receiving either antipsychotics, antidepressants, or both. Additionally, participants with depression and schizophrenia were required to meet criteria for their respective mental illness. To examine brain action, we took functional and structural magnetic resonance imaging below the superior parietal area to limit the activity to the mesonigral striatal orbitofrontal circuit. The scans also included the ventral tegmental area, substantia nigra, and midbrain, which are all part of the dopaminergic pathway, since dopamine helps to reinforce behavior. We modified the Croxon effort-based cost-benefit valuation task to look at the effects of reward instead of reinforcement and evaluate cost-benefit analysis. In this task, participants were instructed to turn off lit-up light bulbs. After, they would receive one of 4 rewards: a gain, a loss, no gain, or no loss, quantified as 45 cents. The person was notified at the end of each trial how the reward affected their balance after each trial. 3 trials of the test were completed, containing 4 reinforcement and 1 null condition within each trial. Positive reward with low or high effort, negative reward with low or high effort, or no reward with no effort. Scanning was conducted during the 3 task trials and during 2 resting states, where participants were told to not think about anything specific. To best analyze our experiment, we observed differences in reward anticipation and behavioral effect, effort-based reinforcement activation, functional connectivity, and amotivation severity with effort activity. In our experiment, we found that absolute cue preference for positive reward was significantly different between depressed and healthy participants, in addition to a significant difference for preference in lower effort. Overall, this data suggests that in depressed individuals, there's a preference for positive reward and low effort conditions. Depressed patients were also slower than healthy participants during all 4 conditions of the experiment. Schizophrenic patients were slower in both positive and negative reward conditions that required high effort. We also examined brain area activation during the effort and reward tasks. fMRI readings suggest brain activation in the visual processing regions, motor cortex, posterior cingulate cortex, temporal gyrus, caudate nucleus, cerebellum, parietal lobe, and the prefrontal cortex. Additionally, there was a difference in the activation of VTA-SN pathway depending on effort levels needed. In healthy controls, the activation increased the most in high-effort negative reward conditions in the VTA-SN pathway. In depressed individuals, the VTA-SN activity was also high for the low-effort positive reward condition. There was also a significant difference found in putamen activity between healthy controls and schizophrenic patients in regards to low-effort activities. It is important to note that depressed individuals had less putamen to right medial OFC connectivity in comparison to the other groups. After analysis, our results support that avolition in depression and schizophrenia could be due to issues in the mesonigral striatal prefrontal circuit. The most significant area present with disturbances was the VTA-SN medial OFC connection in depression, in addition to less putamen activation for less effort needed tasks in both depressed and schizophrenic individuals. The loss of VTA-SN connections and less brain activity in depressed patients is thought to influence their effort-based valuation processing. When looking at the frontostriatal circuit and its relation to amotivation, we found that strengthening the pathway of the medial OFC to the putamen suppresses activity dealing with evaluating effort, showing that the putamen is a major location for effort-based valuation processing. Furthermore, our studies support prior research stating that those suffering from schizophrenia and depression struggle to exert effort for reward-related tasks. We also found that depressed individuals anticipated negative rewards, while those with schizophrenia do not anticipate reward. When it comes to motivation, those with depression are unmotivated by effortless tasks, while those with schizophrenia are motivated by rewards that can easily be obtained. This was found through observations in the putamen and medial OFC. Overall, our findings suggest that reward circuitry is different in schizophrenia and depression than a healthy individual, especially when looking at the VTA-SN functional connectivity and putamen to medial OFC connection. The alterations in these pathways and brain areas are hypothesized to be associated with a weakened dopaminergic mesoprefrontal pathway that could inhibit reward drive, especially in depressed individuals. In those with schizophrenia, it is thought that disturbance to the hippocampus and mesonigral striatal prefrontal connection could be altering reward processing. This study isn't without its limitations. It's important to keep in mind that all patients were medicated. Although this medication is thought to increase connection and frontostriatal activity, that was not found at resting state in our participants. Additionally, our experimental group patients were less educated than those who were healthy. However, ANOVAs did not detect significant association between education and reward or motivation tasks. Overall, our research suggests that disturbance to the dopaminergic pathways and functional connectivity throughout the striato-orbitofrontal regions of the brain could be contributing to avolition and amotivation in patients with schizophrenia and depression. Overall, the researchers conducted a study that was well done. It effectively examined the hypothesis and found results aligning with previous research. However, in future research, a larger sample size for each experimental group should be used to help generalize the data. Additionally, money does not serve as a large motivating factor for some people. For this reason, money could be replaced with a different type of motivation to see if this alters the results. To add to the study, future research could add in another group of individuals that face amotivation but are not diagnosed with a mental illness to see if networking connectivity would change.